All right, so the keys for this is to develop a systematic approach in your evaluation of traumatic patients. Sometimes you just see really cool stuff. Some people call it trauma porn because it's just so addictive, and you're like, whoa, look at that leg. And then you miss the point that they're not breathing very well, and that it's not going to do well unless we take care of that. So it's important to have a systematic approach. I'm going to review some of the serious signs of trauma that can help you figure out, is this patient sick or are they not sick? Obviously they were in a car crash or something. Is there a way for me to tell, besides vital signs, who the potentially critical people are? And we'll review some of the pre-hospital treatment that you can provide to save a life. So if we look at trauma, it comes from the Latin word for wound. And if you go to the dictionary, it basically says that trauma is an injury to living tissue caused by an extrinsic agent. So basically, trauma can be caused by a bullet. It can be caused by a fist. Somebody comes up and hits you in the shoulder and, hey, how's it going? Technically, that's trauma, okay? And so there's different types of trauma. And basically, for medicine, we're concerned about penetrating versus blunt trauma. Because the treatment, you can see on the left is more penetrating trauma, and on the right is probably more blunt force trauma. Okay? So, penetrating and blunt. Penetrating.
What is it though? Is it capitalism?
See? Versus blunt. Penetrating. Versus blunt. This was a patient I took care of. It was at a mill, and that's like a large tap and come off of a tap and die machine, and his long sleeves got caught on a machine, and this is just a big solid steel rod that's threaded for equipment, and it just literally pulled him into this rod. And they were concerned, appropriately so, that if you pulled this blunt object out, that it would eviscerate him. So they were able to blowtorch that solid piece of steel just outside the picture, and then they packed a whole bunch of gauze and taped him down to the backboard and brought him in. And so there's the x-ray you can see with that steel rod going through him. Okay? Versus blunt trauma. What's the typical patient for trauma? You can see that there's this particular spike up here. It ages. So there's this peak right around 21 years old where we see more trauma patients. And then it kind of dips down. And then right about the mid-40s, maybe a midlife crisis, the trauma levels go up a little bit. And then there's this last spike over here where probably they're so debilitated, and that's all the old grandmas that you take care of that fall down, okay? Now, so what do you think? So we know the young people are the highest source of trauma. What about guys versus gals? Okay. Let's see. Well, yeah. In fact, it's true. It's the dudes. So they've been watching, what's his name, Johnny? Crazy Johnny?
Johnny Knoxville?
Yeah, or whatever else the latest version is. That looks cool. Let's do that. By far, motor vehicle accident is the highest incidence of trauma. And then the next highest in the purple or maroon is falling. And that's all comers. That's the little lady that falls at home. That's the guy I took care of the other night that fell from a ladder. He was 8 feet up, not too high, but he fell and still bled in his brain. And I ended up intubating him, and he ended up going to the operating room to drain blood from his head. Okay. You've got some blunt trauma in the yellow, whether it's fist or something like that, firearms, and it really tapers off. There isn't a major causes. So when we think about blunt trauma, there's car crashes, sports injuries, bar fights, falls. So as you keep that in mind, we're not going to talk about penetrating trauma because that's a little bit different. I kind of go back to ABCs, and this is the standard approach. I don't really care what you use, just so long as you cover everything, and you should be consistent, so you don't miss anything. For airway, so a great way to evaluate and assist in airway is we've taught you to push forward on the jaw if they need some assistance, or if they're more unconscious and you're getting your tools ready, you can stick an OPA in. Remember how to size the OPAs? Okay, comes from the ear to the mouth, okay, so you can gauge that. And then there's the nasal trumpets. Some of you rigs carry nasal trumpets. You know about those? Patients like it if you put a little bit of lube on it, because it's a little hard getting it in when it's dry. But they work really, really well, especially somebody that's got snoring. It can really open that up and buy you some time and help get some more oxygen in. And then ultimately, if those aren't working very well, you may have to bag them or intubate them, okay? So the reasons to intubate somebody, particularly in trauma, come about with things like swelling. And so this is an example. This isn't trauma, but here on the left, you see the patient in a normal appearance, and on the right, she had a severe allergic reaction, and you can see she got all puffy. And so we can see that in trauma, and an example of that is in fires. Because of the superheated air, it actually causes a pretty significant response. And so you think about the blisters that you would get on your skin, even if you didn't come in contact with the fire or a hot object, if you're close enough, you can develop blisters. The same thing, just magnified, happens on the inside, particularly in the mouth. And it happens a lot faster. And so the mucosa, the soft tissues inside the mouth and the throat, can really, really swell really quickly, like in 10, 15 minutes. And so all of a sudden you can be having a conversation with the victim that you got out of a burning building, and they seem to be doing okay, and you turn around 10 minutes later, and you hear them going like that, because that superheated air has just caused this huge swelling reaction, okay? So it's important to remember that in those situations, it's time to do an advanced airway. Of course, if they're awake, in your BLS or AEMT, hopefully ALS shows up, because if they're awake, they're not going to tolerate a kink, okay? So another reason to intubate a patient is if there's some kind of a mass. So cancer patients can get trauma, or cancer patients can have masses in their neck. Traumatic patients can have jaw dislocations, so it's tough for them to breathe, or fractures. And so that's another reason that you would want to stabilize the airway. And the last one is protection. So when we talk about people that are unresponsive, the technical reason that we're intubating them is to protect the airway, because they don't have the ability, if they're going to vomit, to not aspirate that, or they don't have the ability to protect against the gag reflex or other tissue debris. So that's why. Another one is secretions and blood. So if there's a lot of blood, you may want to prevent the blood from going down. The other reason that we do quite frequently is the need for positive ventilation. So when you and I breathe, the ribs hold the lungs open, the diaphragm expands, and that sucks air in. If there's some of that is compromised, if there's a hole in the lung, then the lung won't expand when you breathe in. It collapses. And so the only way to get that lung to work is to blow it up with air, and that's how we can sometimes use CPAP or advanced airways to help their oxygenation. So that's why we talk about respiratory failure, and particularly in trauma, people can do that. So even if they don't have any open wounds on the chest, I've seen it time and time again. People are in a car crash, just a split second before, they know that they're about to crash, They're holding on to the steering wheel, and it's just instinct. You hold your breath. And when you hold your breath, you close off the airway here. They crash, the airbag deploys, or maybe it doesn't, and they move forward a little bit, and then their chest is compressed. And so you squeeze the chest and the lungs, and you've closed the airway. And so when you take something and you squeeze it smaller and there isn't a lot of extra space, something's got to give. And the lung can generate a hole in it and it can pop. And so initially when you see them, they may be doing okay and they may be complaining of chest pain because they were in a car crash and they hurt their chest. But actually underneath they could be developing, they could have a collapsed lung. So it's if you're going to do some advanced airway interventions, I want to review some things that we have developed and learned over 20, 30, 40 years that say, you know what, this could be a challenging airway. And this is a lot for the ALS guys, but it's something to think about for BLS or AEMT as you try and seat these king airways or these eye gels, okay? So the signs of a difficult airway is if there's trauma. So a gunshot wound to the face, half their jaw's missing. I think that's going to be a difficult airway, okay? So another one is how big can they open their mouth? And so the way we figure this out is you take 3 of the patient's fingers. And if you think that you can get 3 of the patient's fingers by opening their mouth that much, then there's probably enough room that you can get one of your devices in relatively easy. Some people can't open their mouth that big. And so that's going to be a difficult airway. Another one is if they have really long canines. Why do you think that would suggest the possibility of a difficult airway? Any ideas? Exactly. You know, the teeth should be like this, and you got these fangs hanging down, and you've got to kind of thread that in there. So that adds a level of. Another one is what we call the Malampati score. And this is developed by anesthesiologists. So sometimes you'll hear a doctor say, open your mouth, say ah. And of course it's hard in a traumatic situation, but if they've got their mouth open, the issue here is how much of the back of the throat can you see? Can you see the little thing that hangs down the back of the throat and it's open? Or, well, you can kind of see it, or I can't really see it, and man, there's not even any tonsils that I can see. So the more you can see, the better off you are because it's a bigger space. The less you can see, the harder it's going to be. So go home tonight to your significant other. Hey, open your mouth, say, oh. Kind of an airway. It's really romantic. All right. So here's another one. Buck teeth. Why do you think buck teeth are a potential complication for an advanced airway? It's really hard when they've got those big teeth. Again, you're trying to especially a king airway. That thing's just like this big monster thing, even with a balloon collapsed, trying to get through that. So the purpose of this is to think about that and say, okay, we got to get it. You've already made the decision you got to get an airway, but let's have a couple of people here around. Let's make sure we're bagging them well, because if we're having a hard time, what other options do we have? And believe it or not, studies show that if you have a beard, the likelihood is that you're going to have a more difficult airway. I don't know why.
Why you have a beard?
I know. So, but the studies show that, and it's not clear to me. Because what, if I shave my beard, then my airway is better?
Right.
I don't, okay. So another one is the length and the thickness of your neck, what's called the thyromental distance. So the thyroid is here in your neck, and the distance between your neck and your chin. So you've seen people that have really, really thick necks. And so you're like, oh yeah, that's really thick. And so trying to get the airway in there can be hard. You'll hear some paramedics say, oh, they were really anterior. This is an example of an anterior airway. plus the amount of space here makes a difference. So I think that's something that we all would anticipate, kind of putting it in writing, okay? And then the last one is common is that, well, if you need to put an airway in and their neck is, they can't move their head, then that limits your options to get that in. And we talk about trauma because we put a seat collar on, but another population I want you to remember is the old people. Even if they don't have trauma, even if it's like somebody that's having an asthma attack or COPD, you know, these little old ladies that are hunched over like this, it looks like they're looking down at the ground, but then their head's craned up because they got this big hunchback, you know what I'm talking about? So if you lay them down, what kind of an airway do you think that is? That's going to be hard. Not only are they bent funny, but they're kind of permanently bent. So if I lay you down and your head's turned off to the side, and you're like, no, I need you over here, and you just pick up the head and move it over. No big deal. The older you get, the more the bones get stiff, and so they don't move as much. And so it's like, in effect, they have a seat collar. And so it can make a difficult airway in trying to seat those king airways, or if you're doing it. All right, so let's talk about breathing. Are they breathing? The questions you need to ask yourself, are they breathing? And do you see both sides of the chest moving? Because if one side's moving and the other side's not, even if you don't know what that means, hopefully you recognize that's a bad thing, right? Okay, and that helps you identify this patient could get sick. So, does anyone know what paradoxical movement is? So, when you take a big breath in, do your ribs and your chest go out, or do they get smaller? Go out. They get bigger because you're taking a big breath in. So paradoxical means it goes the opposite. They take a big breath in and their chest caves in. It goes the wrong way. And I'll show you an example of that. Okay? And it's called a flail chest. And so what happens is the chest is able to move open because the ribs are holding it there. If a couple of ribs are broken in multiple places, so you break a rib here and you break a rib here, the middle segment of that rib is no longer connected to anything. So when you suck air in, you're creating a vacuum in the chest, that rib will move in because it's not connected anymore, other than the muscle and the skin. And so if you have multiple ribs that are broken, I don't know how to control this. If you have multiple ribs that are broken, then that rib will cave in. So the treatment for you is they instantly need 100% oxygen because they may have difficulty trying to get that lung to ventilate, and you want to give them as much oxygen as possible. So when you're evaluating the patient, if they don't have any paradoxical movement, you want to listen with your stethoscope, because if they have decreased breath sounds and their trachea is off to the side, and hyper means increased hollowness. If their lung sounds increased hollow and they have decreased breath sounds and the trachea is shifted, anybody have any idea what could be going on? What's that? So a collapsed lung, okay, and we call that a pneumothorax. So what happens is that lung has a hole in it somewhere, and as you breathe in, instead of the air staying in the lung, it leaks out of the lung and collects in the chest cavity. And so as a result, there's air outside the lung, like it is down here. And what happens is that with every breath that they take, a little bit of air leaks out into the wrong space, and it pushes the lung, and it squeezes that lung smaller, 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 smaller. And then, when it's squished the lung small enough, that space continues to fill up with air, and then it starts to push all the organs to the other side. When it does that, people die, because it puts pressure on the heart. The heart can't beat, and they die. Okay? So a collapsed lung has the potential to be very serious, and that's how you'll find. And so if it gets really bad and their blood pressure drops, we call that attention pneumonia. And providers that are in ALS are trained on how to correct that with a 100% non-rebreather and do what's called a needle thoracostomy. So basically, you take an angio catheter and you stick it in the chest in the mid-clavicular line right here. And basically, you stick the catheter in because the lungs already collapsed. And then you leave the plastic tube in, and this gush of air will come out because it's all built up inside the chest. It's an older movie, but have any of you seen Three Kings?
Yeah.
Remember that? That's what he had, was attention pneumo. He put that in, and he had that little valve, you remember? And then it'd get harder and harder for him to breathe. There was one time where I think he was handcuffed or something. He's starting to pass out. He can't breathe. And I finally let him out, and the air came out, and he's like, okay, I'm doing okay again. And so that's what happened, is they were venting that air that leaked out inside the chest. If you end up putting an advanced airway device and you're blowing air into the patient, you should be careful and listen frequently, because maybe they didn't have a collapsed lung, but now you're blowing air into it, you could pop their lung. Because maybe there's a broken rib in there, and as you blow the lung up, it hits the broken rib and puts a hole in it. I'm not going to fault you for it. It's not like we're ever going to know, there's no way for us to tell, but you have to be careful. And so again, after any intervention that you do, whether it's giving medicine or assessing the patient, you should do it frequently, especially if you're breathing for them, to make sure, do I hear breath sounds bilaterally, or is it not, can I not hear the breath sounds as much on one side? And if the pressure goes down, then we talked about it. It's really important. All right, so we've done A and B, circulation. In the traumatic patient, this should happen very quickly, within 30 seconds. I do the same process in the trauma bay. Do they have pulses in all four extremities? Because if they don't, something's wrong. And then see what their blood pressure is. And then the last one is their heart regular or irregular? And that could be an important. Again, we're concerned about blood pressure. So I'll give you an example. You're called to a Little League game over at the local park, and this kid got hit by a baseball and he collapsed. He was unresponsive. Okay? So you're rolling out there and you're like, yeah, don't they make them wear helmets and stuff? You think that maybe he got hit in the head. But in fact, when you arrive, bystanders are doing CPR on the kid. I don't think he's having a heart attack. He's only 8. He got hit by a ball. Really? What do you think happened?
I hit the chest.
Okay. He had a helmet. So when we looked at him, and when ALS got there, this was the rhythm that they saw. There's no electrical activity. And so what had happened was, so they continued ACLS, and ultimately he never survived. And so what went wrong was, commotio cordis. And so there's enough energy in a baseball that hit him in the chest, and it transmitted that energy in the heart at just the right time, at just the right spot. It's a pretty freak accident. And it was like shocking the kid, giving him electrical energy, but it was the wrong. And so now, believe it or not, they have a way around this. So this is what I was talking about, perfect timing. And so when we look at an EKG, this is the normal beat. And if you deliver that energy right at this particular phase of the EKG, it will send the heart into a lethal rhythm. And so if you're a bigger guy like most of us, you can punch somebody hard enough and give them 60 joules of energy. Because joules it's not electricity, it's energy. So most of our defibrillators are defibrillating at 150 or 200 joules. So you can hit hard enough to give 60. So it's pretty significant. Now what they do is somebody invented this thing called a heart guard. Well, you don't really see many little kids playing. Come on, Dad, I want to wear that. You know, Dad makes them put it on their shirt, you know. But basically the bottom line is whether it's at a baseball game or at a bar fight, probably ought to avoid getting punched. Otherwise, these people are the people that you are going to save. And if you don't follow a protocol or an algorithm, you're going to miss it like this kid. And the treatment for these is defibrillation, okay? They will be dead before they get to me. You will save these lives like we were talking about. Question?
So I got a question. So we roll up on the MVA, you do your quick ABCs, no pulse, and we're thinking about, all right, I got to figure out how to get this guy out and protect his C-spine. Am I better off just damming the C-spine, yanking him out of the car and starting the CPR as fast as I can and not worrying about the rest of the...
Yikes, that's an ugly situation. So the question was, if somebody's an MVA and they don't have a pulse, do we yank them out and not be so careful about C-spines and just start compressions? I guess my formal answer would be to say, let's do both. Get them out expeditiously and drag them out onto a board as quickly as you can and try and protect the spines as much as possible. If we save the spine and they die, we lose. If we save the heart and they're paralyzed, it sucks and we lose. So we like for both. So I try and work faster. It's hard because it's not an either and or, but it's kind of a and both. But that's a good question, and it's a lousy situation. This is kind of fun. Remember, just so that you understand, this is a defibrillator. It's an older defibrillator. And for those of you in ALS, this is the indication to use it. This is what the EKG looks like when somebody's about to die. Their heart starts to do this. This is the situation. No pulse. Go ahead and use it. Okay? All right, so part of the circulation, is it regular, is it not? Do they have low blood pressure, and do they have something called JVD? What the heck's JVD? Anybody know? Yeah, so you quoted it, jugular venous distension, but you didn't tell me what it is. Who knows?
Where's the jugular vein starts to poke out because they got bad perfusion going back into the heart, so everything gets back up.
So the jugular vein drains the blood from the head into the heart. If the heart's not pumping very well, then the blood isn't going through. It's going to start to back up. So when they lay back, this vein just really starts to bulge out. So this is a picture of it, okay? And so you can see here, this is a diagram of the heart, and here's the vena cava, the internal jugular comes down to the vena cava. So if the heart's not pumping very well, the blood's going to back up. And so really this is ideally measured when the patient is laying at a 45-degree angle. Of course, our backboards don't usually work at 45-degree angles, but this is where you would look is in this area right here. So not this vein, this is the external jugular. The internal jugular vein runs right between these two palpable muscles in your neck. You can feel it, and if there's a bulge there, a squishy bulge, that is jugular venous distension, and it suggests that the heart's not doing as good of a job. Could be a heart attack, it could be a collapsed lung, it could be fluid around the heart, could be a number of different things, but that's a warning sign that I want to alert you to. That's the external backing up, it's not going through. It can be congestive heart failure, hypertension, pulmonary embolism. They can be having a heart attack, okay? But in a traumatic situation, it's like, well, I don't know, if they're not breathing very well, then maybe that's the cause why the blood's not getting through. To notice. Okay. So in other situations, you could have that JVD, they could have low blood pressure, and then you can't really hear the heart very well. If you add those three symptoms together, some dude called Beck put these together and said, well, I'm going to name this after myself. This is Beck's triad. Anyone know what Beck's triad signifies? Low blood pressure, jugular venous distension, so the heart's not going through heart sounds. Okay? So what it is there's fluid building up around the heart. There's a sac around the heart. And if fluid builds up around the heart, then the heart can't relax and blood come in. And so eventually that fluid basically constricts the heart and the heart stops and they die. Okay? So they can't fill their heart. And so people that are on dialysis can get huge amounts of fluid around their heart. People that have something called pericarditis, or in traumatic situations, you hit the steering wheel at their chest and they get some bleeding in their chest. And every couple of years I'll see patients like this that are brought in and they're talking to me, and while I'm talking to them they just pass out. And then I'm like, holy crap, and I go listen to them, and we have to. So the treatment that we teach the paramedics is to give them high flow oxygen, give them a fluid bolus, and drive fast. Because the other treatment is to take a really, really long needle and start at the xiphoid at 45 degrees and shove that needle towards the heart and just start sucking back until you get blood. And if you go too fast, then you spear the heart. That's not good. Not a good thing. So go far enough that you save the patient, but don't go too far. In the back of an ambulance going 50 miles an hour on the smooth streets of Spokane.
But on that too, Dr. Haggerty, aren't they hooked up to the cardiac monitor? Because when you actually puncture the pericardial sac, you get in there, if the needle touches, don't you see a little spike?
If you go through the pericardial sac, you won't see anything. If you go too
No,
far,
when you hit the heart, you'll see a little spike.
you hit the heart, it'll short circuit the EKG, and you'll see the EKG look funny. Correct. So, but again, it's going so fast, and it's pretty dicey when you're taking. I've done this a couple of times, and you're like, whoa, am I really sure that this is the case? This is a freaking long needle. So, and if it gets really bad, then we just cut their chest open and open them up. And I've done that 3 times in the ER. And there's blood everywhere. The other thing that if they have low blood pressure is in a traumatic situation, they could be bleeding. And so the trauma service teaches us that there are 5 general areas conceptually where you can lose so much blood you can die. The first one is you can put all of your blood volume in your chest cavity. Okay? So you can die if you fill that up. So it's important to examine the chest. You can fill your abdomen with blood. So if they're distended and they were in a traumatic injury, their blood pressure is low, you're like, wow, they're probably bleeding inside. Nothing that you can fix other than give them IV fluids. So EMTs can make a big difference. You can actually put a couple of liters in your back, in your flanks back here. You can break a long bone, a femur, and pack 2 or 3 liters of blood in your thigh. believe it or not, seen that. And the last one that's hard for me is because it got left on the street, and you guys see that. So that's helpful when you do your documentation, so that I can see, was there a lot of blood there? Because this guy's blood pressure's starting to tank, and I don't see anything. So that's what we go through. So you guys will help answer that question. So, ABC, D is basically disability, their neurologic status for trauma. Okay, what are they doing? And so you remember the GCS tool? We printed it on the pre-hospital form so you don't have to memorize it. But that allows us to kind of trend how the patient's doing from 1 minute to the next. And you can assess, it's really easy. Do they open their eyes to verbal command? Okay, and you just circle the numbers and it'll help us track how they're doing. Okay, sometimes they're not acting right because they were just in a car crash and they're scared and they're traumatized. But I think a lot of you have been on enough runs that you can tell the difference between the ones that are just shook up because they were in a car crash and they're actually not doing well. Okay, those are the ones that we want to watch out for. So you want to make sure that they can move everything. Hey, can you wiggle your fingers? Wiggle your feet for me. You want to make sure that all the nerves from what you can see, and of course, protect the spines. So follow the protocols that we have, particularly for the C-spine. If they can't move their legs, you're definitely going to want a longboard. Okay? So it's important to reassess the patients because you can start out with a GCS of 15, and the only way you know that something bad is happening is if you pay attention to their frequent exams and you notice a change in their exam. And so that's the difference between somebody who reads the books and follows the books and somebody who pays attention, and the good pre-hospital providers. They're thinking in advance, what could happen with this patient? Because if we're treating something that's already happened, we're playing catch up. You want to anticipate what could happen. So if their mental status is going down and they're getting more and more sleepy, you don't want to sit there and say, well, let's see how they're doing. Come back in 5 minutes. Maybe you sit there and say, maybe we should put a lot more oxygen on them and get the King Airway nearby because they're getting more and more sleepy and they get to the point that they need definitive airway. And you've prepared so that if they get to that point, boom, you're ready to go. That's how you make a difference. Okay? You save lives. We just did an M&M case 2 hours ago with the trauma service with somebody that had a bad airway outcome, and we think it was about 6 minutes that the airway was not positioned correctly, and they ended up having a stroke on a large part of the brain because they didn't get oxygen, and they can talk in like simple words, and they're like 45 and they're wheelchair bound now. They recovered from their injuries, their long bone injuries, that was all fixed, but the airway issue, they had brain damage from the lack of oxygen, so it makes a big difference. So trending their neurologic status, well, keep in mind that even though you can't see that there's injury, they can still have it. And so in medicine we call this coup and contre coup. It's French. So if you hit the steering wheel, the coup is in the front of the head. And you can imagine the skull stops, and then the brain inside kind of sloshes back and forth. It wiggles back and forth. And when the brain goes backwards and it hits the back of the head, that's called a contre coup. And in some cases, the contre coup injury is worse. And so I'll see that and I'll ask, what did they hit? And so I had a guy that was T-boned, and so his head hit the B post. He was the driver, but he had bleeding on the right side of his brain. So the B post didn't do it, but his brain rattled inside his head, and it injured the right side. That's how it happens. Okay. Don't have bleeding in other places of the brain, but what happens is their mental status goes down, down, down. And so an example of this is these are the things that we look for: a subarachnoid hemorrhage, a subdural hemorrhage, or bleeding in the brain itself that kind of pushes pressure around. And so the treatment in pre-hospital is to try and keep them calm. Oh, my headache hurts. Protect their airway and give them the oxygen that they need and get them to definitive care if you see that their GCS is going. Okay? So, A, B, C, D, E, exposure. So you don't want to miss stuff else. Okay? So, in one of my former lives, I was what's called a denier. A denier is the assistant for a coroner, and I worked in LA. So I worked at the LA County Coroner's Office. And so my job was to come in at 5:30 in the morning, and I would go through, and the bodies had brought in overnight, and I would pull out the bodies and set them up at the different stations for the coroners. And then I would work with one particular coroner for the day, and I would start opening the bodies up as soon as they arrived, and I'd start the incisions. And so I took out this body one day. He was a middle-aged man, and it just, he didn't look like he had a lot of medical problems. And I was like, this is just, and you see old people, and you see trauma where they're in all kinds of bad situations. And it's like, well, duh, they died. But this guy didn't seem to have a lot of injuries. And I read the report, and he was in a car crash. And he was the driver, and they apparently hit something, and the metal from the car door had peeled in. And when the metal had come in, it had cut his leg. And so people had pulled off to the side of the road, and he was still strapped in. And they're like, don't get up. Stay where you're at. The paramedics are coming. That's appropriate. Paramedics are coming. We don't want you, spinal issues and stuff like that. Stay where you're at. So he kept standing there and just get weaker and weaker. Fire and paramedics showed up, and they were trying to figure out how to get him out. They hadn't done their assessment while he was in the car. And it cut his femoral artery, and he was bleeding. By the time they figured it out, he lost so much blood, he died on the scene. Because they didn't notice the bleeding injury. So it's important to expose the patient and see, am I seeing all the potential injuries? And of course, if you don't, there's a lot of internal injuries that are hidden by the skin. I get it. But the simple ones like that, it was tragic. This guy died. And I did the autopsy on him, and he had no other injuries, no head injuries. He just had no blood. I cut him open, and there was no blood in his body. Okay? So, here's some pearls for examining a patient. I'm going to talk about some of the things that will help tip you that there's underlying injuries underneath their skin, what you should do. Okay? So things that can help you decide, do they have the potential for serious injury? What's the car look like? Okay? What's the mechanism of injury? Did they have loss of consciousness? Were they wearing a seatbelt? So a lot of times when the EMS crews will bring people in, I will ask them these specific questions. Did the windshield get broken? And they'll look at me funny because I'm trying to figure out, did their head hit the windshield and star it? And sometimes you can't tell. But that tells me about what kind of injuries they may have sustained. Were they wearing their seatbelt? Were their airbags deployed? Was the steering wheel bent? They actually did a study that showed if the steering wheel is bent, there was such mechanism of injury that instantly the rate of death increases by 20%. Just by having the steering wheel bent. So there was so much force, okay? And of course, if there's a fatality at the scene, then something bad was going on. And so you should have a heightened awareness and pay close attention to this because they could have some serious injuries. Question?
Can we go back to the femoral artery for a minute?
Okay. Femoral artery.
If you're in that situation, what's your preferred method to control that bleeding?
The question is, what's the preferred method to control bleeding, if, for example, in the femoral artery? It's the same method for all bleeding. It's point pressure. Okay? That's where I would start. A lot of times we get excited, we get these big ABD pads because we want to soak up the blood. We want to keep it clean. Keep the house tidy and all that kind of stuff. Put this big ABD pad on and wrap all these gauze so it's just not dripping like this. I don't care. the bleeding will stop, the dripping will stop if you control the blood, if you put point pressure on it. Just like anything else. You cut your hand, what do? You are you putting pressure more proximal? I hope not. If you cut your finger while you're slicing slicing vegetables at home, you're gonna put pressure over it. Now, if you can't get control because it's such a big wound and you're putting point pressure on it, that's when you start to say, okay, maybe we need to go more proximal to an artery, in effect like a tourniquet, because this guy's gonna bleed out. But the number one solution that will get you 90% of the bleeding is point pressure, okay? And that's all somebody needed to do, was to reach inside the car door on this poor guy. They didn't have to get him out, they didn't have to extricate him, reach through the broken glass door and just put pressure and wait for the rest of the crews to cut this guy out, and he died, okay? Thank you, it's a good question. Things that you might see that suggest that there's possibly some serious injury. The first one is called raccoon's eyes, and the other one is called battle sign. This is bruising, and what it means is that they hit their head hard enough that they cracked the bones inside their skull, inside the base of the skull. So there's bleeding inside, and then the blood tries to find ways out. And gravity will go back here, and it will puddle in the eye. It looks like this. Here's an example of raccoon's eyes. Okay, right here. And then here's an example of battle sign behind the ear. That takes a little while. It could take 15, 20 minutes for it to show up. So if things are moving well, and you've got ALS or transport there, you may not see that right then and there. But my instinct tells me that typically you guys are on scene a little longer than just 10, 15 minutes. And so you may start to see that. And that tells you, if they're still talking to you, that's awesome. But you're like, oh, this guy got hit hard. Bloody eyes. Okay, again, it's symbolic that they sustain significant force. They could have a skull fracture, or the eyeball could actually pop, which would be bad. Okay, so sometimes you'll see this. We call it an 8-ball, and so basically all the white is just covered in blood except for the front, and they hit their head pretty hard enough that they broke all of those vessels. I actually had one where the lady she was in a car crash. She got hit so hard, not only did it break it, but it popped her eye out. So the paramedics, understandably so, were scared. They're like, I didn't want to touch it because it was literally hanging out. The doors to the ER opened, and I hear this screaming. I'm like, what the heck? And so the paramedics, they're bringing the gurney in as fast as they can. Where do we go? Where do we go? Where do we go? Where do we go? What room? What room? And so I'm walking by, and she's just going like this, and her eyeball is hanging out. So I put on a sterile glove, and I went like this, and went, So if their eyes are bulging out, and hopefully they haven't popped out, but if they're bulging out, that could be a bad sign. Is that they could have bleeding deep inside their face, where some of the bones inside the skull have been broken. And so this is a cut like this. And so here's the brain, and here's an eye socket, and here's the eye socket. See, here's the eyeball. See the round thing? That's the eyeball, and this gray thing back here is blood. And so what it's doing is it's pushing the eyeball out, down and out like this. So you'll see that. And it's not hard. We don't notice it, but we look at people's eyes a lot. And so this is kind of obvious, like, you look kind of funny. No, you look kind of...
I hear that a lot.
So again, in the setting of blunt trauma, that's a bad thing. And you should be worried that they could have bleeding in their brain, or that they could have airway issues. Another one's a seatbelt sign. So you want to expose the patient. And again, you may see this develop as you're taking time to extricate them, and get them out on a board, this may start to develop. And so it's significant force. And obviously, you know, I see people that are like, well, this is a good reason why I shouldn't wear a seatbelt. I'm like, no, you're misunderstanding. You're misunderstanding. So that's pretty significant. Pain out of proportion to exam. They can have a collapsed lung. They can have bleeding in their stomach. So that's a physical examining that you can find that would tell you that there's something bad. Extremities. Well, if their leg's pointing the wrong direction, obviously it's bad. Okay? You want to check neurologic function and make sure that they've got pulses. Okay? So if you take the leg and you lay them on a board and you just kind of rotate the leg in and out, that shouldn't hurt. It's kind of like the hokey pokey or whatever that is. So it shouldn't hurt. But if you do that and they scream, they could have broken their proximal hip. Okay? Sometimes patients will, their toe will be pointed inward. So this is my left foot. It's pointing inward. What can happen is if you're in a car and you're sitting like this and you get in a car crash, the knee hits the dash and it actually dislocates the leg backwards into their butt. And so then you lay them on the board and they scream because their hip bone is actually pointing, instead of into their hip, it's pointing in their butt cheek, and now they're laying on it, and it hurts. So their leg's short and it's internally rotated, okay? And you have to be worried about a pelvic fracture, and they can have low blood pressure from that, and they can bleed out. So in summary, these are some symptoms that you may see with leg foreshortening or facial symptoms, and it's important to have a systematic approach. Again, I don't care what system you choose. This is one I've suggested, but you want to do a head to toe. You don't want to miss something. Save somebody's life before they get to me. They could die before they get to me. So anticipate the difficult airway. How much can they open their mouth? Do they have any of these signs that if you need to intervene, you're like, okay, let me get a couple other people here, or what are the tools do we have to reduce the risk that we're not going to be able to get this airway in? So remember all those. Okay? Don't forget to examine the patient. Are they breathing? Both sides of the chest working well? What's their pulse like? Is it fast? Is it slow? You have these clinical skills. I'm not asking you to be a doctor, but to just assess these simple things can make a huge difference. And you know what these mean. You may not be able to tell that they have Boerhaave syndrome from esophageal rupture from a car crash. But you can tell if they have a collapsed lung and if they're not breathing well, and you can help prepare and anticipate and fix it. Okay? Always trend patients. Examine them over and over again, because that may be your only clue that they're changing. Okay? And by noticing that change, then you can act preemptively and prevent anything bad. All right? So I think this is...
Are we noticing the gender? Going off here too?
All right. Thanks for your time tonight.
Thank you.
Doc Hager. Doc Hager.
Yes.
Do you have any insight into,
Hang on, guys.
there was that truck accident